Good morning. I'm really grateful for all the people that managed to turn up on a Sunday morning. That's quite something. I'm the warm-up man for the panel. And what I'm going to do is give you a quick 20-minute overview of where we are in the prisons at the moment with HIV and also hepatitis C, because it's impossible to separate the two. And also to try and give you some indication of where I think we're going, and then to talk a little bit about the problems of delivering healthcare to HIV and hepatitis C infected in the people in the prisons. Actually, I should go back to that conflict of interest. I have a contract with Corrections Canada to provide by telehealth care for HIV patients in the federal penitentiaries across Ontario. The conflict actually runs both ways, because Correctional Services Canada and I quite frequently do not see eye to eye on matters of clinical care. So prisons are a significant reservoir of HIV and some other communicable diseases. And CDC in Atlanta estimates that 20 to 25% of all HIV-positive individuals in North America are in custody or prison or in touch with the correctional authorities at any time. And for hepatitis C, the figure's over 30%. Now, I think they may be overstating a little bit the HIV figures, but the hepatitis C figure is probably correct. Just to remind you, federal versus provincial. If you get 2 years and a day, you go into the federal system. If you get less than 2 years, you go into the provincial system. And in Ontario, which is my bailiwick, we have 2 maximum security, 5 medium security, and these are getting fudged. Because they're running out of space in the max, they're putting maximum type offenders into some of the medium institutions. 3 minimum, 1 psychiatric, and 1 women's. Total prison population in Ontario was about 5,500. I discovered from the newspaper yesterday that I'm a little out of date with the total for Canada. It's expanding rapidly, and it's not 12,000 anymore. It's getting close to 15,000, and will get worse. This is Kingston Penitentiary, as you read in your newspaper yesterday, or was it the day before? This institution is about to close. It was opened in 1835, for quite a long time before Alcatraz, and Alcatraz has been closed for about 40 years. This was the first prison in Canada to actually have a remit to rehabilitate people rather than just punish them. It sometimes seems as though they've forgotten that remit. This is some of bits of it they've painted since it was built. This is a range, and some bits they haven't painted. And it's probably a good thing all around that it's going to be closed down. Now, if we look at how much HIV/AIDS we've got in Canadian prisons, there have been a number of studies, but nothing very recent that's very useful. Or not in the federal system anyway. In British Columbia in 1994, Dr. Rothon looked at the HIV rate for people coming into prison. They were tested on admission, and for the males it was 1.1% and females 3.3%. In Ontario, Calzavara in 2007 published a study that on admission to provincial prisons, the HIV rate was 2.1% in males and 1.8% in females. And we did a couple of studies, actually 3 studies in federal prisons in Ontario, but the most recent one was published in 2000 when the HIV rate was 2%. Now, Corrections did their own study, but they did it by questionnaire. Do you think you're positive? And asked about a whole lot of risk factors. The people who thought they were positive were 4.6%, which the CSC made the mistake of actually publishing. Rothon had actually asked her prisoners when they were being admitted whether they thought they were positive, and 63% actually turned out to be negative of the ones who thought they were positive. So I don't think the CSC study is actually worth very much. If you look at the bottom right-hand corner here, you'll see the United States figures for 2006, 7, and 8. For the line above the bottom line is federal prisons, 0.9%, 0.9%, and 0.8%. And for state prisons, it's 1.8 1.6 and 1.6. So there's a sort of suggestion that, in fact, the rate is falling. It varies quite a lot across states in the U.S., which does not seem to be the case in Canada. We seem to be fairly constant from one side to the other, but you can see here there's quite a range. And this was in 2004. In the U.S., you go to a state prison for a state crime, so murder is a state crime. If you rob a post office, that's a federal crime, and you go to a federal prison. So they tend to have a better class of prisoner, like Conrad Black. Now, in Ontario, we have a skewed population. Just to mention that in the context of some of the other things that you may see, but 32% of Ontario federal inmates were born outside Canada, and 19% are immigrants from countries with high endemic rates of disease, such as HIV, tuberculosis, and particularly hepatitis. So we have 40 to 50 HIV patients under care at any one time. The interesting thing was that when we did that study in 1998, that was published in 2000, the prevalence was 2%. And that 2% of HIV positives in that penitentiary, we knew about half of them. The other half had not declared themselves. Some of them knew they were HIV positive. There were one or two surprises. And I think this is a fairly constant. We had seen the same thing in 1994 when we'd done a previous study. So about half the individuals detected positive represent half the total population of HIV. And so probably for every 40, 50 we're looking after, there are another 40, 50 who haven't told us or don't know. And one of the things that confuses what we're looking at any one time is there are many frequent flyers. There are a lot of people who come in and go out and come back again because they violate parole. Why don't people identify themselves to health care as having HIV? Well, if you've got a short sentence, and if you go in for 2 years and a day and you behave yourself, you can be out in 6 to 9 months. It's probably, they think it's a lot less hassle. It's easier to go through their sentence without having to declare themselves and all the problems with confidentiality. One of the issues that comes up frequently is what's the evidence for HIV transmission within prisons, and that's pretty hard to put a finger on. The Macalino did a study in the US in 1994 where they looked at 446 HIV-negative prisoners who had been negative for 12 months, and they followed them for another 12 months, and none of them seroconverted. Good heavens, I don't know what happened to that slide. There was an interesting outbreak in Scotland amongst intravenous drug users. That was back in 1997, where 13 of 14 infected individuals who presented over a fairly short space of time were identified by molecular sequencing to probably have a common source infection. And so these were all drug users. They looked as though they'd all been infected from the same source. It's worth remembering that hepatitis C is a sentinel indicator of risk behavior for HIV infection. There's a lot of it in the prison. In 1998, our study showed 32%. The 2004 Ontario provincial study showed 16% in males and 30% in females. So 32% of federal prisoners is a lot of people with hepatitis C. 55% of our, I'll get back on that, of our HIV positive federal prisoners, and that should be hep C, not HIV, co-infected. So 55% are co-infected. Now the interesting thing here is watching that particular trend tells us that something's changed, because 5 years ago it was 90 to 95% were co-infected with hepatitis C. And what we're seeing now is a shift in the risk behavior that got people infected and the sort of people that we're seeing. So we're seeing less intravenous drug users, and that would be to be expected. This is Health Canada's numbers year by year of intravenous drug users, males in the black line, females in the grey line. who are testing positive. And you can see that number's declining, and we're seeing that in the prison. And the slack is being made up by imprisonment of people who have sex with people without telling them they're HIV positive. And my current prison population has a very significant number of those people. So our population is changing a little bit. Drug use in prison is a big deal, and it's interesting that in 1994 we did an anonymous study and asked people who was injecting, and 12% of prisoners had injected while they were incarcerated. When we repeated the study in the same prison, obviously with some different people, 4 years later, 24% had injected. And one of the things that had changed in that time was that they had introduced random urine testing. So they could fish a guy out of the yard and make him go get his urine tested. And so people stopped using marijuana because it hangs around for a couple of weeks in the urine, and took to using things that disappeared more quickly, like opiates and cocaine. And the other interesting thing from that study was 67% of those who had only ever injected in prison were hepatitis C positive. So we have clear evidence of quite significant transmission of hepatitis C. Most of these hep C positives are IVDUs. Many of them come into prison already infected. So there's a large pool of addiction in the prison population. HIV care in prison has advanced immensely. I've been looking after HIV-positive patients in prison for the last 25 years, and when we started, the health care offered was, I think you could reasonably describe it as medieval. My wife, who's a physician, started going into the prisons at the same time as I did, and she had the experience one day of finding one of her prisoners breathing into a brown paper bag. He was short of breath, and the health care staff thought he was hysterically hyperventilating. He was, in fact, cyanosed, and after a fairly brisk exchange of views between her and the security, she got him transferred to hospital, where he subsequently died of PCP pneumonia. The standard of health care, the standard of observation of what was going on was simply appalling, and it has improved immensely. We are now delivering, I think, a very reasonable standard of care at the sort of work phase, so to speak. So there are problems with delivering health care in prison. Where is the prison? Some of them are in the middle of nowhere. Warkworth, for instance, is sort of equidistant between Peterborough, Toronto, and Kingston. It takes about 2 hours to get there from anywhere. So transporting prisoners becomes expensive, becomes something that the prisoners are reluctant to undertake, and so are the prison authorities, because it's expensive. A prisoner seen in hospitals or in prison health care, we stopped seeing prisoners in hospital because shackling a guy to a wheelchair and having 2 guards wheel him into the clinic really wrecks confidentiality, because the guards know what the diagnosis is and that gets back. And there may be impediments within the prison to accessing health care. Maybe movement may be difficult in maximum security prisons. So there may be geographical access problems. Confidentiality is always a problem. We've had instances where the list of people to see Dr. Ford has been posted on the range, and everybody knows what I do in the prisons because I've been going in for so long. So if you take people out to clinics, then everybody knows what the diagnosis is. We have very severe mental health issues. Attention deficit disorder is actually, the letters are in the wrong order, which reflects my attention deficit disorder. There have been estimates that as much as 50% of the prison population actually suffers from attention deficit disorder. And I have patients who cannot finish a sentence without changing the subject. So it's really difficult to get these guys to take their medication properly. We see a lot of depression, schizophrenia, personality disorder, and also brain damage from folks who've injected too much funny substance. Co-infection is a problem. You need to select people who are not currently injecting, and that's difficult to assess. We're now seeing people who we have cleared the hepatitis C and getting reinfected in jail as well as out of jail. So the issue with hepatitis C is whether to treat at all and when to treat. Antiretroviral treatment of HIV, there's good news there. We can use any drug that has been cleared by Health Canada. And so we can use drugs that are not available on the street in Ontario, for instance, because the provincial government's not paying. The one hooker there is that you can't discharge a patient on something that he's not going to be able to get on the street. And so you have to pay attention to that. Managing side effects is somewhat difficult in prison. Prisoners get locked up for long periods. There's not much to do. Quite trivial side effects can become all-consuming. How successful is treatment? Well, we've come on by leaps and bounds. When we started, it was quite difficult to get people their medication in a timely fashion. Now that doesn't happen. It's been made much easier by single-dose medications given in the morning. So in 2000, we had 25% of our inmates on treatment with undetectable viral loads. Currently, it's 90 to 95%. And one of the interesting things is that our patients go out and they stop taking their medications because they go back to what they were doing before, or drugs or whatever. So we have people who come in on parole having stopped their meds 3 months before. We start them up again. They go out. After a few months, they come back in again. We're seeing very little drug resistance. These guys are getting frequent drug holidays without apparently developing very much resistance. I'm just going to briefly mention medications other than antiretroviral therapy because we have a lot of problems here. And I'm going to focus particularly on peripheral neuropathy, which can be painful and can really wear people down. If you want to for instance, prescribe amitriptyline for pain at night, which is the standard of care. I'm not allowed to do that. The psychiatrist has to do that. So we refer the patient to the psychiatrist who says this patient's not depressed and doesn't give them the amitriptyline, and so we're back to square one. So this is a major problem. And gabapentin likewise. We can use gabapentin if you have a positive nerve conduction study. Well, it takes 3 months to get a nerve conduction study, and by that time they've moved the patient to another prison, so they never get it. Misuse of medication is part of the problem here because anything that's possibly give you a high gets abused. So believe it or not, if you take enough Gravol at once, particularly inject it, you can get quite a spectacular high. So that makes it difficult to give patients some of these drugs in the prison for fear they will be misused. And methadone, for instance, has to be given, followed by applesauce, followed by sitting the patient there for 20 minutes or so, because otherwise they're liable to go back to the cell and regurgitate it for other people to use. If you do not address the addiction problem, and we have a lot of addiction problems in the prisons, it's going to be difficult to treat HIV and get compliance, because addiction is the overwhelming interest here, and you have to address that in one way or another by substituting, such as using methadone, or by drug rehab programs, which simply aren't available in the prison. There are a few Mickey Mouse ones that really lack very effectiveness. And part of the problem is they get put down at the time of sentencing as a compulsory program, must-do drug rehab program, where if there isn't one, you can't fulfill your programs, and so you don't get parole. It's a sort of you can't get there from here problem. I'm not going to spend time, I think, on methadone. There are big problems with discharge planning and parole. And we have an expert on that on the panel, so we can discuss that at some length. But I'll just say that the problems are many. If you've got a patient on methadone, they have to go somewhere where there is a methadone clinic. And then Northern Ontario, that's quite difficult. The parole board will make clean urine as a parole condition. And this is idiocy in a drug addict, because the first thing many of them do when they go out is they take drugs, they fail their urine test, they come back in. They might as well not let them go in the first place. Compliance with HIV treatment after release is a major problem. I would think that probably 60, maybe even more % of our patients actually stop their meds when they go out. And ability to access ongoing health care is a problem. We have many patients who go out who had a doctor on the street, and when the patient reappears from the penitentiary system, the doctor says, I don't want to see you anymore. And so we have to put an unreasonable load on some doctors in some cities by asking them to see our patients. And in Toronto, most of them go to a single clinic. So discharge planning, we can pay a little bit more attention to during the discussion. I'm going to talk a little bit about harm reduction because that's a major issue all the time. And in fact, it's got to the point where correction staff are actually not allowed to use those two words. And a physician dealing with a group of patients who not only have transmissible diseases but continue to indulge in transmitting behavior, it's our moral responsibility to get involved in efforts to both promote education and to promote implementation of harm reduction strategies within the prisons. And this leads to considerable friction with the authorities. This, some of you will have seen before, is a homemade syringe. This was actually brought into our clinic in Kingston by a guard who'd managed to stick himself in the finger with it while doing a cell search. This syringe has probably been used, as far as we can tell, by anywhere between 25 and 50 different people. And as you can see, it's made from a ballpoint pen, probably an old diabetic needle, and a lot of sticky tape. And I defy anybody to actually clean this. It's not cleanable, and it's a lethal weapon. There are countries with prison needle exchange. None of those countries have English as their primary language. Some of them are extremely unlikely. Some of them most people haven't even heard of. Moldova, Kazakhstan, Armenia, Iran all have prison needle exchanges. So I'm going to close with the Tackling Violent Crime Act, just to point out to you that longer sentences and less parole is going to increase health problems, particularly those associated with aging and addiction. And we're beginning to see that happen now. Now, if I could invite the panel up onto the podium here. I'm going to get them to do is spend 1 minute each telling you who they are and what they do, and then we will open it up to question and answer. Yeah, please don't destroy the infrastructure.
My name is Diane Smith-Merrill, and I'm the Prison Support Coordinator for HIV/AIDS Regional Services in Kingston. And as most people know, Kingston has a large prison population, so I do a lot of different things in the prisons. I do education and advocacy. However, the lion's share of my work is pre-release planning, for people remaining in Ontario, people remaining in Canada, and people being deported to countries outside of Canada, which presents a lot of challenges, which we'll talk about later. Anyway, thank you.
Hi, my name is Kathleen Griffin. Mes pauvres amis québécois, je m'excuse, je vais faire ça en anglais. Anybody who knows me, I'm a diverger, so I'm all over the place. So I wrote what I wanted to say today. I'm not here with you today to talk about fuzzy cognitive mapping variable concept, but rather to put a face to the families and friends of persons who are incarcerated in a provincial and federal system. Too often, families and friends are the forgotten voice of the correctional system. We are the silent voice living with the shame, the guilt, and the stigma of the offenses committed by the ones we love and support, perhaps ostracized from our own community. Having spent over 20 years as an HIV/AIDS community worker, I've seen the impact and high-risk behavior in federal and provincial prison. By tattooing an illegal act in prison, my husband infected himself with Hep C. I'm grateful that's the only thing he infected himself with. In the past 20 years, CXC has implemented some harm reduction measures that are not part of what is called the Commissioner directives. The problem that I have seen is the lack of consistency from one institution to another. Too often, the respect of these directives are left to whomever is in charge that day. Just one example is going from having bleach provided in the private family visit units in the institution without any problem to now having to request bleach 7 days in advance. Personally, I don't need bleach during what is called a PFV or a conjugal visit. But as a passionate community worker, I see there a warning signal. Slowly, some harm reduction measures are pushed aside, and Correction Service Canada is starting by what affects the family first, because it's an easy way to go. I did not make a fuss about the bleach because I knew if I do so, my husband and us will be targeted by IPSO. IPSO is like the police that works in prison. I have heard over again this weekend how multidisciplinary approach is vital to treatment of HIV and AIDS, NFC. Just accessing health care in some provincial and federal institutions would be a good start, and I'm still waiting to see standard care in institutions. We are far from ever seeing safe tattooing or needle exchange in prison. 10 years ago, I chose to spend every day of my life that my Creator gives me to a wonderful man serving a life sentence. I also chose the consequences of my choice. My husband has been incarcerated numerous years when we met, and the impact in my life was different. If I leave you with only one thought today, is behind every man, woman serving time in Canada, there's a mother, a father, a brother, a sister, or maybe a child who has not made the same choice that I have. Their fears and worries are real, and who will be there to answer them?
Hi, my name is Richard Elliot. I'm the Executive Director of the Canadian HIV/AIDS Legal Network. You can find some more information about the legal network on the table at the back. We're a national AIDS organization that has been working on human rights issues related to HIV for a number of years, including the rights of people in prison. And I would invite you to look at our website, aidslaw.ca, and see a number of publications that we've produced over the years on the issue of harm reduction and other human rights issues in prisons, including a report called Under the Skin, which was a collection of testimonies, first-hand accounts from people currently or formerly in prisons across the country, talking about their experience of drug use in prison and of sharing injection equipment. I'd also invite you to look at our report called Clean Switch, which is the legal and evidentiary case for implementing harm reduction programs such as needle exchange in prisons. We'll talk a bit more in the discussion that follows about why we think this is an important human rights issue that needs to be attended to very shortly.
Okay, at this point we're going to take questions from the floor. I'd like people to step up to the microphone if they're going to ask a question so that we can hear clearly what's going on.
Sorry, we weren't sure which mic you were talking about.
Sorry, the microphone down there.
We want to thank all of the panelists for sharing your information. We want to thank you as well for your presentation at the beginning. Something we feel that has been missing from the conference and the discussion is the impact to Aboriginal people's health, particularly as it relates to the most recent funding cuts that are disastrous violations of human rights and absolutely impact the health and well-being of people who are incarcerated and families who are incarcerated. So we have a statement that we would like to read very quickly in regards to this correlation, and we invite anybody else who feels the same way or stands with us to come and stand with us here at the mic. So this is a statement we put together really quickly, written by grassroots Indigenous peoples who are involved in Indigenous health all across Canada. So we know that it has become overwhelmingly clear amongst the community of Indigenous health service providers, public health representatives, and all of our communities nationally that the conservative government has made targeted cuts to undermine programs that are critical for the subsistence of frontline work within Aboriginal communities and also within the prison system itself. The prompt rollout of these decisions as of much lately has resulted in the near inhumane, on-the-spot firing and or suspended employment of many frontline Aboriginal health workers and those in prison. This is part of a long history of solely government-made decisions that continuously fail to consider the legacy of colonialism, genocide, and other trauma that gravely impact the state of Indigenous health outcomes. For example, Indigenous peoples, and specifically Indigenous youth, are disproportionately affected by HIV due to many factors, including assimilation, the legacies of residential schools, and other social, political, and economic isolations. The Government of Canada has a fiduciary responsibility to uphold the health of Indigenous peoples of this land, regardless of on or off reserve, whether in Northern Territories or large urban centres. Government has the obligation to uphold these rights for land seized and resources stolen. Canada has clearly not been upholding its duty to implement, because while we see these rates of multiple health disparities in addition to HIV, such as suicide, cancer rates, and diabetes increasing, their responses to act are ever decreasing. When Indigenous health is not made a priority, our self-determination as Indigenous peoples is not made a priority. As Indigenous communities, our family networks extend beyond our immediate kin. We work within our communities in proximity to our own, but also with those across the country and internationally. Our national Aboriginal organizations who do work in health are one example of this kinship circle, and our worldview is that we are families and collective communities. Canada claims to be an upholder of human rights in which health is of great importance, but their actions speak quite differently. Canada said it fully endorsed things like the UN Declaration on the Rights of Indigenous Peoples, but continues to make cuts to Indigenous health in which it's violating its own internationally binding human rights documents. In addition, the apology for their residential school experience that was given by government in June 2008 was recognized as a so-called historical moment, but holds little substance with the ongoing removal of these rights. The actions since this apology are an indication of the lack of commitment behind the apology, and healing as it relates to health is a central part of our self-determination and the next generations. In closing, the delays, reductions, and outright cuts in funding create an environment of instability and endanger the delivery of effective health resources. Furthermore, it is up to the discretion and leadership of Indigenous peoples to decide what frontline healthcare looks like to us in our communities, not the Government of Canada. We therefore urge all of you here, urging government, the Ministry of Health, and everyone to take immediate action against these funding cuts and continued policies of forced assimilation. We demand that Indigenous peoples be supported to determine their own health and the ways in which health is taken care of. If you allow people to help themselves, take care of their communities, and be strong, we will flourish. Thank you. We have copies of the statement right here, so if anybody wants a copy of the statement to give out within your organizations, please come and see us. Thank you for your time.
Thank you very much. Do we have any questions from the floor?
Hi, Dr. Ford. Thank you for a great presentation. I just have a quick question on intermittent ART that occasionally, I did a study years ago in San Francisco looking at recidivism in jails and intermittent ART. So do you have a sense of, how many inmates return and how many are linked to CAHR and how many of them are on intermittent ART compared to never on HART? Because that helps. We found that, never on therapy was, of course, we know all of this, but
Diane,
I'm Nikki Pai from McGill.
Respond? Can you stand a little further away from the microphone and just repeat the last question?
Okay. How many inmates in your jails are continuously on therapy? How many have intermittently taken therapy? And how many have never been on therapy? And has anybody looked at long-term hard outcomes and soft outcomes?
Pretty well everybody who I know about is on treatment. For HIV, that is, not Hep C. The Hep C is a little more difficult problem. We have taken very seriously the reasoning that if you treat people, you make them less infectious and therefore reduce spread in the prison. So I would think that of the people that I see, 90% are on treatment. There are always some people who refuse to take treatment, and there's nothing you can do about that. And there are one or two people who are simply too mentally unstable to put on treatment because they probably aren't going to take it. But otherwise, everybody gets treated.
I have a question concerning hepatitis C. You said you weren't really seeing drug resistance amongst the HIV positive individuals who went on and off therapy. For the hepatitis C individuals, are you seeing drug resistance occurring if they're sort of transiently the ones that you do manage to catch that are transiently doing therapy?
We're talking hepatitis B here?
No, sorry, hepatitis C.
One of the things about hepatitis B is that there's about 1% prevalence last time we had a look. The immunization is freely available in the prisons, so many people who pass through get immunized. Hepatitis B is sort of suppressible but not really treatable at the moment with the drugs we have available.
I'm actually asking about hepatitis C, not B.
C. We're not seeing, we see people who fail to respond to hep C therapy, which presumably represents some sort of innate resistance, but I don't know about specific drug resistance from the virus. A lot of people do not get treated because they're still actively injecting, or their liver disease is simply not significant. I mean, we do liver biopsies on a lot of them, and if there's no change and the titer of virus is not very high, we don't treat them because it's not regarded as justified. So to answer the question about resistance, I do not know, because we have no resistance testing.
And also one second question, if I may. This is, I guess, maybe for the rest of the panel. If I were a prisoner and I voluntarily went in, when I went in, I voluntarily submitted for HIV, HCV testing, is that looked upon favorably for when I apply for parole? And if it's not, why is that? Why not?
You want to answer that, Diane?
There's no implications if you do or don't. And the other thing is, it's offered to everybody. And at any point during your sentence, you can have a test done. So it's not really looked at as far as parole eligibility. What the nurses have told me, though, the infectious disease nurses, is that when people go in to prison, that generally they're anxious, so that they're more likely to have all the medical care that they can receive. So they find that most people will get tested, but there's no implication for parole. And as a person can get tested at any time during their sentence if they feel like they've been exposed. But yeah, there's really no implication. That's not noted on their parole that I'm aware of.
Thank you.
Okay.
My name is Mark Wainberg, McGill University, Montreal. I just want to say first that I personally identify with the statement that we heard earlier from members of the Aboriginal community. My question to the panel and to Dr. Ford is that we currently seem to be in a situation in regard to Canadian prisons that might be in flux. We're closing prisons, and yet the government has stated that it wishes that the prison population expands, and it's not clear what measures will be taken in order to accommodate an expanded prison population. Some people have suggested that we might go the route that seems to be favored in the United States, whereby prisons become privatized. And I wonder if any of you would like to comment on how you see the future of the prison population in Canada unfolding in years to come. Thank you.
I'll answer that first, and then I'll get Richard to respond, because he's probably got an eye on this sort of thing as well. What do I see as the future of the prison population? I see expansion for two reasons. One is they're going to put more people inside, and secondly, it's becoming more difficult to get parole. And that's not something that happened with the last bill against violent crime. This has been happening for the last 3 or 4 years. We've seen people coming up for parole eligibility who simply aren't getting parole. And so, we're stopping the efflux from one end and increasing the influx from the other end. So I see expanding population. They're already building. It's the largest government building project in Canada currently is building more bits on existing prisons, and I don't see that getting any smaller. Richard, do you want to comment on that?
Only to say that I think it's likely what you will see is, because of Bill C-10, the omnibus crime bill, you'll see an increase in provincial prison populations faster than federal prison populations, I would guess, although we'll have to see. And I think what you will see within the next 5 years is a greater push for privatization. I think that all the signs are pointing that way with this government. And I think it's inevitable that when you introduce even more directly a profit motive into the prison industrial complex, you will directly see an increase in the frequency of human rights abuses because of the corners that will be cut in the interests of maximizing profit and reducing costs. I think it is a recipe for disaster for human rights and for public health to go in that direction, and I think the evidence is clear from the U.S. And that, I think, is the direction we're headed, unless those of us who care about these issues actually stand up and speak out. And I, too, would associate myself with the statement that was just made a short while ago about funding cuts.
My name is Martin French from Queen's University, and I'd like to thank you, Dr. Ford, for your talk today, and the panelists as well for being here, and also say that I support the statement that was read out about the denial of Indigenous health and self-determination. My question is about stigma and segregation. And we know that in the United States, a report was published by Human Rights Watch that shows that in 2 states, I believe Alabama and Mississippi, prisoners who are positive are actually segregated from the general population. Now, this is not an official policy in Canada, but I would ask if you could, and perhaps the panelists could comment on stigma more generally in prisons and how that acts to informally segregate people in prison.
I think both Diane and Kathleen could probably respond to that.
It's a mixed bag, and I don't have any research, sort of anecdotal situations, but for the most part, I haven't heard a lot of the fellows that I work with complain. I have some gentlemen who prefer to go into seg on their own, at their own request, because they said it's quieter and they don't have to deal with people trying to muscle them for medications, which sometimes becomes an issue. Other time, I have some gentlemen who are quite open about their status and talk to other people, other offenders inside about HIV, and others who are quite secretive. So it's sort of, I haven't heard of any, as I say, official research. It's only by what I talk to people. They do say there are some COs, correctional officers, who if they lend them a pen or to do something, will tell them to throw it in the garbage when they're done with it, or you know, I'm not sure whether it's just being malicious or whether it's actual stigma. So I guess that's the best I can do. I don't know any formal, but anecdotal. There's some very little that I've heard of.
I would agree with Diane, but I think it's more, you know, prison is a culture in itself, and I mean, I can just tell you an incident recently where one guy was talking to the other, and the other one says, "Oh, ask the AIDS guy." The guy has HIV, and everybody knows. So ask the AIDS guy. So it's more that it depends of the institution. It depends of the culture of the place. Some healthcare professionals are great in Corrections Canada, and some sadly are not. So, but I don't think it's as bad as in the States. I think anything is not as bad as in the States when it comes to Canada, but personally, but I don't think the stigma is and the fear is as much as it used to be. I think that's one thing that's been okay.
Now, one of the things that gives you problems with stigmatization is ignorance. Mm-hmm. And I think in many prisons where they have peer health teams, the prisoners are much better informed about what's going on health-wise than the guards are. Okay, next question.
I think I think it almost was answered, but I was going to ask a question about how possible culture of violence in prison affects stigma, which may affect people wanting to go get tested, access treatment, and the like, and also even possibly be part of education programs that speak to that issue specifically. So I don't know if you have anything in addition to say about that.
One thing that corrections did very well is they have what they call PECs. They're inmates that are trained to be helpers. It boils down to credibility and trust. If the PEC that's on, like where my husband is, there's an Aboriginal PEC, there's a guy who takes care of the Aboriginal community that's very high where he is, and another PEC. If they have credibility and trust, they'll get the word out. They'll get tested, they'll help guys get treatment, they'll get guys having different workshops. If the guy in charge, the PEC, is not credible, nothing ain't going to happen. That's reality. If the healthcare there is open, the healthcare nurse that's working with him is great, she's trusted, she has credibility, it will work. If she doesn't, ain't going to work. That's how correction works in the inside.
There are problems with people who are on drugs that are perceived as being useful for giving you a high. Those individuals may get muscled for their medication, and that can be a real problem. You can get around it to some extent by directly observed therapy in the hospital area, but if they have to take tablets away like Tylenol 3 for persistent pain, they may not actually get to take them because somebody bigger and stronger is going to take them away. And we perceive that as a problem, and it's a hard one to do very much about. I'll take one more question, then we have a brief video on harm reduction that Richard wants to show.
Hi, my name is Dana. I'm from Elizabeth Park, Toronto, and we work with women who have been or at risk of being in conflict with the law. In the presentation, you were also saying that there was lack of availability for treatment. I know that the inmates in there, they have to follow a correctional plan, which is from working or education. Is there any way that they could also implement, in the correctional plan, to take some type of treatment if they are aware of if they have Hep C or HIV or whatnot?
If I heard the correction, you asked if they could implement ways to force them, because that's
so
what
you said there's not availability of treatment,
health.
Right? So is it because there's no treatment in the correctional facility, or
I think when we were talking about correctional plans and whether it's a drug rehab program that would be part of a correctional plan, and I think what Dr. Ford was saying is that sometimes they're so backed up or doesn't exist that they can't actually take what's part of their program plan.
Well, the availability of the
treatment. But as far as health care, treatment and health care, is that what you were really, that's not a problem. It doesn't go on their correctional plan, and anybody who wants treatment, as Dr. Ford was saying, it's much better can access treatment. So that's for HIV and Hep C. The correctional plan pertains a lot more to behavioral issues or things related to their crime, whether it's violence against women, drug use, all those sort of things go into their correctional plan. But the actual medical treatment is aside, and they can have access to that at any time.
Okay, and another thing was, I know that the drugs in the institution is an issue, and the way that it's coming into the institution is blamed, like a lot of stigma is that it's blamed on the families which are bringing it in, or inmates or whatnot. But is there anything around the workers that are in there, which are the ones that are mainly bringing it in?
I'll just speak briefly and then.
I'm not even touching that.
I think in the news we've seen recently, it's a mixed bag, but I think in the news has recently been charges against different employees of CSC for smuggling in drugs. And as a matter of fact, tobacco has become, for a while there, tobacco was probably is still a hot commodity they created this underground economy with tobacco when they banned smoking in all prisons and on the grounds outside. So it's a mixed bag of people, but there have been some recent articles about staff smuggling in.
But a lot of things are kept underground when it comes to correctional officers being involved in those type of stuff. I just wanted to say also, like, the security of families going into the institution, just to bring light to, I guess, the audience, that they know what they're doing when it comes to security. So it's hard for families to even bring in anything if that's the case. So just to bring awareness to the fact of there's several searches that are done before families even get into the institution to see their loved ones. It's very difficult for them to even attempt to bring in anything. So just to be aware that people need to be looking at the other ways that it's going in and not really blame things on the families. Thanks.
Thank you. One more question, and then we're going to show them. I dare not cut Dr. Gilmore off.
You can try. How's that? Navi Gilmore, Miguel, Montreal. Thanks for a great session, a whole issue that has been, I think we've got our eyes open dramatically. I guess my question really is one that could take a long time to go to answer, but keep it quick. Where should we be going in the future? For instance, you can't mention harm reduction. I was thinking about this and saying, well, maybe we should start a program of HARPA reduction from what we're hearing today. But where should we be going? How can you not so much deal with the issues inside, but the broader issues as well, and as an organization or as a healthcare system or as a country? Where might we be seeing ourselves going, or what can we do best? And I think that would be maybe a big question, but maybe you can give us some little ideas that we could do.
Richard, do you want to tackle that one?
I'm going to give you a very biased and specific and focused part of the answer. I don't pretend it's comprehensive. I think that what we are observing with public policy making that is not just completely devoid of relationship to good, sound evidence much of the time, but sometimes actually flies directly in the face of it, means that we need to look at other fora where the use of evidence and the use of principled argument may have a little more traction. And one of those fora potentially is the judicial system. We've seen in a number of circumstances that, to a certain degree, the courts have been willing to play a bit of a check on bad public policy. Now, I don't want to overstate it by any means. I think our courts have been far too timid. Certainly when it comes to imposing positive obligations on the government to actually address a whole range of injustices and determinants of health and so on, they've been far too timid and have pulled their punches too often. But if you think about recent examples like the Insight decision from the Supreme Court of Canada, where they said, no, the criminal law to prohibit drugs can only go so far, and it goes too far when it produces predictable death and disease. It must bend in some way to accommodate the existence of things like supervised injection services. Then I think that offers a little bit of hope. When we see the courts step in around sex work laws and actually say, no, the criminal law goes too far when it contributes to the risk of harm for sex workers, something has to give in the law. There are opportunities that present themselves for the judiciary to actually uphold human rights, to uphold the use of evidence in making public policy. I don't want to overstate it, but it is one tool in the toolbox that we ought to be thinking about using more.
Thank you. Bill, just briefly, and then we've got a small video to show.
This short question has a one-word answer, and I would like to direct it towards the lawyer on the panel.
You want a lawyer to answer in one word?
Yes.
Not possible.
Oh boy. Canada subscribes to international human rights, which include life, liberty, food, security, shelter, and especially security of the person. If we suspend the liberty of a person and then deliberately place that person in harm's way, harms from violence, harms from multiple infectious diseases, harms from all kinds of stressors and insecurities, is there no liability for violating those people's rights? Is there no liability of the incarceration system or our government for those multiple harms to which we deliberately expose our citizens? Yes or no?
Depends.
No. Inadequate answer.
Yes.
Mr. Moderator, is there liability?
Well, I would think there was, but it probably has to be proved at this point.
The answer is yes, if the court finds it. So let's ask the courts.
Thank you, Bill. We're going to show a brief video around harm reduction, and then maybe a little bit of discussion after that. But can we start the video?
No, we got to wrap up.
We started late.
Yes, we did. Yeah, drugs came down. Drugs came down for me through the food line, and came with a syringe that looked like it had been through a war. I was actually, my first inclination when I saw it was to flush it now, really quick. I can just snort this or something, but it was really dull syringe. It was had been chopped in half at some point, and the tip that you would hold on to pull the plunger back had been melted down and made into a hard little nub, and so it was black and it was dirty. And I know people used it after me. I'm 39 years old. I'm a single mom. I have 2 daughters. Definitely a history of poverty, really low-paying kind of dead-end jobs for much of my life. More recently, was privileged to graduate from a college-level program. For me, and I think for many people, drug use is a survival. It's a survival tool. So it's how you get through the day. It is how you cope. It is a way of coping. When I was released from prison, you come with a criminal record, now back to society. You come with that stigma, and it's very difficult to find employment. People think of you differently. People have all kinds of weird ideas and misconceptions about who goes to prison and why. Anyone who has suffered a trauma and coped with that through drug use has the potential to become a prisoner. You know, I never learned how to cope with any of that earlier stuff. Never dealt with it, never addressed it. And it affected every part of my life, my relationships, everything. Sometimes I was criminalized strictly for the drugs that were in my possession. Other times it was for what I was doing to pay for the drugs. So shoplifting usually was my thing. And that's what most of my record is about, shoplifting and drug possession. I was aware of some instances at various times where women were using used injection equipment while they were inside. Had been able to get a package from whatever means. It happens, and then, of course, it affects the people at home, people that you have future relationships with. If you're injecting in prison, you're using used equipment, and your chance of contracting HIV or hepatitis are extremely high. And I don't think anyone should be subjected to that. There's no reason for it. I myself have hepatitis C, and, it definitely came from sharing equipment. Most prisoners are coming home. The vast majority of prisoners are not there for life. They're going home to their families. You're always without your children if you're in prison. But whether they're safe or not is an additional trauma. Who they're with, who's looking after them, that they don't know, even if they're taking good care of them, they don't know all of the nuances. They don't know to rub your little one's back to sleep at night. They don't know what her favorite stories are. All of those things are traumatic. The government's own statistics show that about 80% of people who are incarcerated have problematic drug use histories, and many of those are injection drug users. And if you think about the reasons behind why people use drugs as a coping mechanism, as a way to get through the traumas of life, of their past, of the present, if you could put your drug use in check, you would have probably done that already. Prison itself is a trauma, and believe me, people are wishing for their coping tool while they're there.
I think we have to cut it short at this point because I'm getting ugly gestures from the chairman down the front. So thank you very much.
Merci beaucoup. Thank you very much for this session. It was very, I think, interesting. Now, I would like to announce the award for the young investigator. So, I don't know if we have the slide to announce them. They've been chosen by the track co-chair, and for the basic science, do you know? Please. Yes. Lara Ajamian, I don't know if she's present. If she's, please come on the stage. Was new investigator, don't need to be so young, and for the clinical science, Laurence Brunet. For epidemiology and public health science, Sheetal Patel. Don't know if I pronounced very well. If she present, yeah. Because if you are not, I was keeping your check. And finally, in social science, Surita Parashar, teacher. Et avant de passer la parole pour les mots de la fin à Jean-Pierre et Jonathan, j'aimerais beaucoup remercier les membres du comité de CAHR pour la confiance qui ont fait preuve en m'offrant de coprésider cette 21e édition du CAHR à Montréal. Je vous remercie beaucoup de votre présence. Je pense que ça a été un bon cru. On est très satisfaits. Et vraiment, merci beaucoup. Puis je passe la parole à Jean-Pierre.
Thank you. I think this venue was extremely good by the crosstalk, the multidisciplinary presentation. I'm particularly pleased by the rapporteur session done by community members, and I think this vision by those in most need for to improve HIV care and treatment and prevention is a great idea and give a vision and a lesson for us and to tailor the future CAHR. And also the gala last night was outstanding. I'm just asking maybe next year to have 5 coupons of alcohol and not 3, so it will be even better. So without further comments, let's our president, Jonathan Langeol, have le mot de la fin.
So thanks everybody for attending CAHR and staying to the end. It's very much appreciated. It was an excellent conference. I don't have to repeat Jean-Pierre's words, but I think this was an outstanding conference in all respects. So it's just my responsibility to officially close the conference, but couldn't do that without thanking some of the people. I'm not going to go through a long list, but Ian Holiday from Sea to Sky did an outstanding job with all the organizing, all the logistics. He's already gone, I think, to organize his next conference, but he really needs to be thanked. And of course, the two co-chairs, Jean-Pierre and Pierre, like to come up and give you guys get a gift. Now, you've been handing out so many gifts, you get your own. And there you go. On the podium. Thanks very much, and see everyone next year.